Hello and welcome. I wish everyone a very happy new year and a very good evening. We welcome you all to this webinar, which is being hosted by the Rare Disease India Foundation. And the topic for today is a very interesting topic. It is LSD treatment and management. I have with me a galaxy of speakers, and I hope after this webinar, we do have something to learn. And I myself am looking forward for this particular webinar. To introduce myself, I am Dr. Dipanjana Datta. I'm a medical geneticist and I practice out of Calcutta, East India, from from Institute of Child Health. And I am honored to be here. Thank you Singh, who has very kindly asked me to moderate the session. Moving forward, much ado, I would introduce our main person over here, Mr. Saurav Singh. He's the co-founder and director of Rare Disease India Foundation. He's actually the father of rare disease child Shaurya, who is suffering from MPS II, commonly called as the Hunter syndrome. He has done his MBA and worked for 15 years in various multinational companies. He's the person who left everything behind to access treatment for his son and many more patients in the country by formulating this organization RDIF. Before we start, I would request Mr. Saurav Singh to please give a welcome note.
Good evening, everyone. As Dr. Dipanjana has said, Saurav Singh, Director, Rare Diseases India Foundation. It is my pleasure to welcome all our eminent speaker, moderator, and all attendees today who are watching us from different corners of this world. And now I would like to appreciate Sanofi Genzyme for supporting us for this great cause. I also thank to our strategic partner. Rare Disease India Foundation is a patient advocacy group. It is established in 2019. This is a non-profit organization which works for the benefits of the patients and to raise awareness about rare disease in the country. Rare disease is not a disease for a particular person, but it is the disease for the family. The entire family is involved to manage these diseases mentally, physically, morally, and financially. As we all know that rare disease are very few in numbers and mostly it is genetic. Only 6% to 8% of population of India is affected with rare disease and 72 to 96 million people affected by rare diseases. There are so many challenges in rare diseases. Either there is no treatment available or the treatment is unaffordable by an individual, which is generally comes in crores of rupees. Second challenge is early diagnosis of disease. It is also one of the challenges of this country. Lack of awareness about rare diseases, including doctors and the patients. Government does not support fully for rare diseases. Parents are bound to watch their children dying every day. We all know that in the month of March 2021, the government of India has formulated a revised rare disease policy, but that too is not very much effective, especially for group 3 diseases, which includes lifetime treatment, but cost is very high. To discuss in detail about these issues, today we have the best speakers of India and abroad from different renowned hospitals. First of all, I would like to welcome our chief guest, Dr. Ashok Velot from London, UK. I also welcome our eminent speaker, Dr. Sumita Danda from CMC Velot. Our another speaker is Dr. Ashwin Dalal from CDFD Hyderabad. I welcome Lieutenant Colonel Dr. Aradhana Dwivedi from RNR Hospital, New Delhi. And last but not the least, most welcome to our moderator, Dr. Dipanjana Datta from Institute of Child Health, Kolkata. Over to you, Dr. Dipanjana.
Thank you so much for the warm welcome. I do welcome all the people who have joined along with us, and I welcome all the speakers and our chief guest to this session. Team, if you can please play the video.
हेलो, मेरा नाम लतिका दुआ है, मेरी उम्र 24 है। मैंने कॉलेज ऑफ आर्ट्स से फाइन आर्ट में ग्रेजुएशन कंप्लीट की है। मेरी हॉबी ड्राइंग, पेंटिंग, स्केचेस है।
मेरा नाम मयंक दुआ है, मेरी उम्र 22 साल है। मैं नॉर्थ डीएमसी मेडिकल कॉलेज हिंदूरा हॉस्पिटल से एमबीबीएस थर्ड ईयर की पढ़ाई कर रहा हूँ। मुझे क्रिकेट खेलना, पढ़ना और ड्राइव करना बहुत पसंद है।
लतिका को मैंने देखा 2003 में, इसकी बैकबोन में बैंड है। मुझे लगा कि इसकी रीढ़ की हड्डी टेढ़ी क्यों हो रही है, तो मैं इसको लेकर सेंट स्टीफन गया। वहाँ पे डॉक्टर दिखाया तो डॉक्टर ने कहा आप इसका इलाज यहाँ पर नहीं है, आप एम्स में जाइए। हम एम्स में गए थे। वहाँ पे डॉक्टर ने हमें एडवाइस दी कि इसका एक टेस्ट होगा MPS टाइप 1। हमने वो टेस्ट कराया। टेस्ट की जो है बाहर गया था इंडिया से, काफ़ी खर्चा आया उसमें। तो लतिका को पॉजिटिव पाया गया। डॉक्टर ने कहा अपने बेटे को भी लेके आइए, उसका भी टेस्ट कराएंगे। बेटा भी पॉजिटिव पाया गया।
MPS टाइप 1 एक जेनेटिक बीमारी है और ये बहुत ही रेयर है पूरे वर्ल्ड में। इसमें एक एंजाइम की डिफिशिएंसी हो जाती है जो कि बॉडी में प्रोडक्ट एक्यूमुलेट कर जाते हैं और ये जॉइंट स्टिफनेस और जॉइंट पेन करते हैं। ये हार्ट प्रॉब्लम्स भी कर सकते हैं और मेंटल रिटार्डेशन भी कर सकते हैं। एम्स के डॉक्टर ने हमको एडवाइस किया बोन मैरो ट्रांसप्लांट के लिए। 2004 में मेरी बहन लतिका का बोन मैरो ट्रांसप्लांट हुआ एंड 2005 में मेरा बोन मैरो ट्रांसप्लांट हुआ। बट बोन मैरो ट्रांसप्लांट के बाद भी कंडीशन पूरी तरह इंप्रूव नहीं हुई थी।
कुछ हद तक आंखों की समस्या ठीक हो गई थी। डॉक्टर ने कहा अगर नहीं हुआ तो इनकी कॉर्निया भी चेंज कराना पड़ेगा, जो कि ठीक है। अब फिर इनके हाथ पैर में दर्द होने लगा, सिर में दर्द, तो इनको एक्सरसाइज की ज़रूरत थी। तो फिजियोथेरेपी के लिए एम्स में आते थे। आए दिन हर हफ्ते कभी ऑटो से कभी बस से। पैसे की प्रॉब्लम, तनख्वाह इतनी नहीं थी। जैसे तैसे मेरी वाइफ को समझाया कि हिम्मत मत हारो, बच्चों को स्ट्रॉन्ग बनाना है, इनको नहीं बताना कि बच्चे बीमार हैं। 2008 में हमारी आशा की किरण जागी। हमें खुशी हुई, एंजाइम थेरेपी ने चैरिटेबल द्वारा हमें दवाई देना शुरू की, जो कि दवाई हमें मिलती रही। उससे बच्चे इंप्रूव करते हैं, उनके हाथ पैर भी ठीक होने लगे और उनके कोई दर्द नहीं होने लगा। 2018 में मैंने ऑफिस में लिख के दिया, तब जाके वहाँ से मुझे सपोर्ट मिला, वहाँ से दवाई शुरू हो गई है।
13 साल हो गए इनको दवाई मिलते हुए और अब थोड़ा सा लगता है कि बच्चे अपना फ्यूचर खुद बना सकते हैं और पढ़ भी रहे हैं अच्छे से, आना जाना भी अच्छे से है इनका और कोई दिक्कत नहीं आ रही अभी।
मेरी बेटी जो है PFA कर चुकी है, आगे पढ़ना चाहती है। बेटा मेरा MBBS कर रहा है, जो कि थर्ड ईयर चल रहा है। मुझे खुशी है कि बच्चे मेरे पढ़ रहे हैं। मैं उनको कभी महसूस नहीं होने देता कि आप जो है बीमार हो।
हमारे फैमिली और फ्रेंड्स ने हमको काफ़ी इमोशनली और मेंटली सपोर्ट किया। हमको कभी अकेला महसूस नहीं करने दिया और हमको बहुत स्ट्रॉन्ग बनाया। और आज हम ये MPS के अगेंस्ट लड़ाई लड़ भी रहे हैं और जीत भी रहे हैं।
बचपन से ही मुझे ड्राइंग का बहुत शौक था। स्कूल टाइम पे मुझे ड्राइंग में बहुत अवार्ड्स मिले हैं। फाइन आर्ट में ही मैंने अपनी ग्रेजुएशन कंप्लीट करी है। मैंने अभी मास्टर के लिए भी अप्लाई किया हुआ है। मैं आगे टीचिंग लाइन में जाना चाहती हूँ। मैं बच्चों के ज़िंदगी में रंग भरना चाहती हूँ।
मुझे मेडिकल फील्ड में काफ़ी इंटरेस्ट था और मुझे डॉक्टर की पर्सनैलिटी मुझे काफ़ी अच्छी लगती थी। तो मैंने अपनी डिग्री भी MBBS परस्यू करी और आगे मैं PG कोर्स करके एक अच्छा डॉक्टर बनना चाहता हूँ। लोगों की हेल्प करना चाहता हूँ, उनकी लाइफ ईजी करना चाहता हूँ। We are not MPS patients, we are MPS warriors.
That's such a beautiful video of hope and of courage. In India, if we look at disorders, there are a number of disorders, and WHO at one point has said in around 2003 that India is a country where non-communicable disorders would be more than communicable disorders, primarily due to our marriage cultures, consanguinity. If consanguinity is also not present, we practice endogamy. If we look at today's topic, it would be lysosomal storage disorders, and these are a group of disorders which are very rare, and they generally come up in children who under 5 or around 5, the detection is there. And this actually holds a group of about 50 disorders, and many of these disorders are manageable or treatable if detected very early at birth. Especially because in some of these cases, some of these LSDs, which are very common, they in India, like the Gaucher, the MPS, the metachromatic leukodystrophy, few of them have enzyme therapies, and they drastically change the lifestyle of a person. As you can see, these two children, if we look at the average lifespan, it would have been about 13-14 years, but with the help of the lifespan generally improves, and so does the other factors associated with this. Without spending much time, and in order to know more about it, I would like to introduce to our panel of speakers, and to express the first, to sort of render the first lecture of this pocket of webinars on LSD treatment and management. I am very glad to introduce Dr. Ashwin Dalal. He's the Head Diagnostic Division, Center for DNA Fingerprinting and Diagnostics, Hyderabad, India. He is affiliated as an adjunct visiting professor, Department of Medical Genetics, Kasturba Medical College, Manipal, and his areas of interest are exome genome sequencing for recessive disorders, chromosomal breakpoint characterization, genetic analysis in lysosomal storage disorders. Today, he will be speaking on diagnosis of lysosomal storage disorders, which is very important because these are a group of actionable disorders and they can actually bring a change. Dr. Ashwin Dalal, please, if you can, render your talk.
Thank you, Deepanjana, and thank you, Saurabh, for invitation, and good evening, all of you. So today we will, just now we have seen a very encouraging video of how the children affected by these disorders are really fighting this disease. And mainly for the clinicians now, let us go through why it is important and how we go about diagnosing these lysosomal storage disorders. So although all rare disorders are important, these group of disorders gained importance because of availability of the enzyme replacement therapy, which really changed the way we manage these disorders. So, but the first step of identifying the patient is through a diagnosis. Without a diagnosis, no therapy or no other benefit can be given to the patients. And it is very important that the primary clinician, whether it is a pediatrician or a general medicine doctor or a general physician, that he suspects these disorders whenever there are clinical features and then does a proper diagnosis so that the patients are having a clear-cut diagnosis. So these lysosomal storage disorders are a group of about 40 to 45 disorders with prevalence ranging from 1 in 5,000 to 1 in 8,000. In India, we still do not know the prevalence. And all these disorders are usually caused due to accumulation of storage products because of some or the other enzyme deficiency. So the diagnosis is basically based on the clinical features, some of the screening tests, followed by confirmatory assays and the molecular analysis. So clinical features that typically are seen in various lysosomal storage disorders include coarse facies, as you can see here, or corneal clouding, joint contractures, you can see here, umbilical hernia, hepatosplenomegaly, neuroregression, and classically dysbiosis multiplex on the X-rays. Now, any of these conditions should encourage the doctor to go ahead with further diagnosis of the condition, because without knowing the exact diagnosis, we really cannot inform the patients or counsel the patients. So there is a lot of overlap of clinical features. You can see just among the 7 mucopolysaccharidosis disorders, we have such a large amount of overlap based on the clinical features. So it is very difficult to decide which test to do based on the clinical features, and hence we have certain screening tests which help us to screen out for particular disorder. So these include mainly the screening test for mucopolysaccharidosis and the oligosaccharidosis, and the confirmatory assay is then decided based on the clinical features and the screening tests. So one of the screening tests for mucopolysaccharidosis is the toluidine blue spot test, which is a simple spot test on the urine, which can just detect presence of glycosaminoglycans in the urine. And then you can either do a quantitative analysis or a qualitative analysis for the glycosaminoglycans. So, and then followed by that, you can do a MPS electrophoresis to detect which particular glycosaminoglycan is present in the urine. And these glycosaminoglycans, they are polyanionic, and hence they can be moved in a electrophoresis. And you get these typical patterns like in MPS 1, you will get heparan and dermatan sulfate. You can see the bands here. This is MPS 6, which is Marrow syndrome, where mainly you get dermatan sulfate. And in MPS 3, which is mainly a neurological disorder, you get mainly the heparan sulfate band. So based on the presence of dermatan sulfate, heparan sulfate, chondroitin sulfate, and keratan sulfate, different MPS disorders can be thought to be present, and then a confirmatory diagnosis can be done. Similarly, for oligosaccharidosis, which consists of diseases like monocytosis, fucosidosis, Farbus disease, galactosialidosis. So all these disorders, again, you can do a thin layer chromatography. So these are some of the examples. You can see this is a thin layer chromatography for GM1 gangliosidosis. This is for Niemann-Pick disease. This is for aspartyl glucosaminuria, which again help us to decide which particular enzyme to do. So the main work of the screening test is mainly to decide which enzyme assay is to be done, and the confirmatory diagnosis is always by enzyme assay. So the indication is mainly for confirmation of diagnosis in the proband or prenatal diagnosis of the lysosomal storage disorder. So these enzyme assays are done in leukocytes present in blood, plasma, or on the fibroblasts in prenatal diagnosis. We use artificial substrates for the specific enzymes, and measurement of fluorescence or absorbance is done, which can be done either by colorimetric or fluorogenic method. So you can see here, this is the substrate which is attached to a fluorogenic dye. And when the enzyme which is present in the patient's blood acts on this particular substrate, the dye is released and this fluorescence is measured, and it is expressed in nanomole per milligram per protein per hour. So it is very important that it is expressed in terms of protein. So enzyme activities are measured in the cell extracts and then compared with the reference sample. And we should always remember the enzyme amount is not measured, the enzyme activity is measured. And patients with deficient enzyme activity, usually less than 10%, is considered as affected. The sample requirements are basically a EDTA or a heparin vial blood or chorionic villi or amniotic fluid cells. And preferably this sample should be sent in cold packs to reach the laboratory as soon as possible, but preferably within 48 hours. This is because the enzyme gets degraded if kept for a longer time. And for interpretation, it is very important to correctly interpret. So any enzyme report will have the enzyme activity in the patient, followed by a range, the normal range, then the units, and what is the percentage of mean. So this is very important. From the range, you take the mean, and what percent of mean enzyme activity is present in the patient is important. And unless it is less than 10%, we should not say that this patient is affected. And always the alternate enzyme activity is measured in any patient. This is because we want to rule out any enzyme degradation in the patient. So there are certain pitfalls of enzyme assay, like it is a labor-intensive technique. There is specific tissue is needed in certain diseases, like in skin biopsy may be needed in Pompe disease. There is loss of enzyme activity in transport, and there is large degree of overlap between carriers and normal individuals. So we cannot use enzyme assay for carrier detection, and there is a lot of variability in the results, and correct interpretation is very important. And that is why molecular analysis is preferred nowadays after an enzyme assay. It helps in accurate prenatal diagnosis after diagnosis in the patient, and a small amount of sample is enough, whereas the enzyme assay needs a larger amount of sample. And proper carrier detection can be done in the family by expanded family screening or population screening using the molecular analysis. So this can be used both for diagnosis, prenatal diagnosis, as well as carrier detection. And it is done by sequencing of exons and the exon-intron boundaries for the particular gene for which the enzyme deficiency is present. So let us see these two case presentations where just we show how we go about diagnosing a patient. So this is a 3-year-old female who came to us with delayed milestones, coarse facies, short stature, hepatosplenomegaly, corneal clouding, joint contractures, and dysostosis multiplex, which we can see here in the hand here. So this kind of clinical features are mainly pointing towards a mucopolysaccharidosis. Mostly either it could be type 1 or type 3 because there is delayed milestones. So this is from the clinical features. We have a differential diagnosis in mind. Then we do the MPS screening test. We see that toluidine blue test is positive, which confirms that it is a mucopolysaccharidosis. And then electrophoresis shows that there is heparan and dermatan sulfate present, which points towards a Hurler syndrome. And then we do the enzyme assay for alpha-L iruronidase, and that shows it is 0.5 nanomole per hour per milligram protein. And as I told you, you have to always see the normal range. So you take 50% of the normal range, that is the mean. And what percent of mean is this particular value? So it is less than 10%. which tells that this patient is affected. And there is another enzyme which has been done, which is in normal range. So this whole report now tells us that this is a patient of Hurler syndrome. So once we have the diagnosis, we can counsel the patient that it's a progressive disease. There is some sort of a treatment available in terms of enzyme replacement therapy, but it is quite expensive. And if there is already intellectual disability, then the treatment may not be effective. Then again, we have to tell them about the inheritance pattern, that it is recessive inheritance. There is a risk of 25% risk that it can happen in the next pregnancy, and prenatal diagnosis can be done. Similarly, this is another patient, female child, 4.5 year, born out of consanguineous union with normal milestones, normal birth history, came with growth retardation and progressive distension of abdomen. You can see there is a huge hepatosplenomegaly, coarse faces, but here there is no mental involvement, no corneal clouding. And so here, the differential diagnosis here has to be considered non-genetic as well as genetic diseases. So you should consider infectious diseases, hematologic malignancies, as well as mucopolysaccharidosis or other storage disorders. So some investigations showed, like ultrasound showed hepatosplenomegaly, bone marrow biopsy, there was no evidence of malignancy, and liver biopsy was showing a lipid disorder. So cherry red spot is a very important investigation which helps us to narrow down to a few lysosomal storage disorders. So cherry red spot was positive in this patient. So we have done the thin layer chromatography for oligosaccharide, which was normal. The MPS screening was normal. So because cherry red spot was positive, we have done the acid sphingomyelinase assay, and that again shows a deficiency activity compared to the normal range, and another enzyme is normal. So here we have a diagnosis of Niemann-Pick type B. Here we say type B because there is no intellectual disability. In type A, there will be neurological involvement. Type B doesn't have neurological involvement. And when we do the mutation analysis, we can see these peaks of ATGC, and we can clearly see that the patient is having a homozygous mutation compared to the normal, which diagnosis in this patient, and this information can be used for prenatal diagnosis. So we again have to counsel the patient regarding all these aspects about the diagnosis, about the inheritance pattern, about the prenatal diagnosis, and carrier screening in the family. So in this way, we can go through a systematic way to diagnose the patient, and that is the first step, after which we can go ahead with proper management of the patient. Thank you.
Thank you so much, sir. That was such a comprehensive yet very well presented presentation for diagnosis. And at the same time, there were certain takeaway points over here that number one, we need to also rule out the differentials in some cases. And in certain cases, it might be that one test might not be enough. We need to probably depend on certain array of tests to understand the diagnosis. In my experience, sometimes enzyme tests are more informative, because when we move on to molecular diagnostics, in certain cases, especially like Hunter or Gaucher, we do miss mutations, because these mutations can be deep intronic or in regions which will not be covered in the normal sequencing we do. So though it makes very difficult to understand carriers or do a prenatal diagnosis in these cases, but in the index child, normally with the enzyme studies and the clinical features, a diagnosis can be provided. We move on to our next speaker, and our next speaker would be Dr. Sumita Danda. Ma'am, welcome to the webinar. She's a professor and founder head of Department of Clinical Genetics, CMC Velot. She has been awarded the GP Elhens Gold Medal for Best Postgraduate Student in Medicine in 1992. She has been a clinical fellow in medical genetics and Women's and Children's Hospital, Adelaide, South Australia. She's a life member of Indian Medical Association, life member of Indian Society of Human Genetics, life member for Mitochondrial Research and Medicine India, and life member for Society of Indian Academy of Medical Genetics. Her areas of interest include dysmorphology, lysosomal storage disorders, neuromuscular disorders. Today, ma'am would be presenting on LSD treatment and management. Over to you, ma'am.
Thank you. Good evening to all of you. I thank the organizers and Mr. Saurabh Singh for this opportunity. I will very briefly present an overall view of the management strategies and leave it to our chief guest, Dr. Velot, to give his expert opinion and more time so that we also can learn from him. Going over to my talk. Just a outline of what is the healthcare system in India, about LSD, the management target goals, prevention, rare disease policy, and the future. So if you see the healthcare delivery system in India, it's a public and a private component, where the public has a primary, the secondary component, and the primary is at the rural areas with community health centers, primary health centers, and sub-centers. And the secondary, it's district hospitals, and at tertiary, there are the district hospital and medical colleges. And private can be profit and non-profit NGOs. So our CMC is actually a private institution, but we can see that it is in close partnership with the public health system as well, as it has been seen over the years. So if you see that every level we require a teamwork and we require a collaboration, because the primary health physician or the clinician is the main person who is going to reach out to the rural areas and to the community. So if we work as a team, then together everyone achieves more. So this is the teamwork which is going to really tackle the rare diseases, and one of them is lysosomal storage disease. So if you see here that rare diseases are over 7,000 diseases, and in India also is no exception, and there are a lot of 80% of them are actually genetic in nature. And after thalassemia, sickle cell anemia, and ataxia, the lysosomal storage diseases come in the fourth place. And it is a rare disorder where you actually need educational programs, awareness, social media, involvement of government, diagnostic facility, just as Dr. Ashwin has told, health policies, funding, and motivation for the parents and the family and the patient as a whole. So when we see the success story of Litika and Mayank, this helps in motivation, and such awareness can be created or spread out that will lead to more people benefiting from the policies and the procedures which can be helped to make the management better. So if you see, the lysosome is the main organelle which is involved, and there are different types of involvement which can happen. So there is a lipid storage abnormality, which is the main problem in Niemann-Pick type A and B. There can be a glycolipid like in Gaucher disease, or glycosphingolipid storage like Fabry, so mucolipidosis, and then the glycogen storage like Pompe, or the glycosaminoglycan storage, which are the range of the mucopolysaccharide diseases. So all these are happening in the lysosome, which is a very small organelle in a cell. So any of these proteins which are coded by the genes can be affected, and these are all genetic disorders. So if you take an overall view of the lysosomal storage disease, and I'm going to put Gaucher as a prototype, you can have symptom-based intervention and disease-specific therapy. So symptom-based intervention can be so many symptoms such as pain, the orthopedic procedures, bisphosphonate, iron supplementation for anemia, or procedures like for MORQs, where you have to correct the atlantoaxial dislocation and the joint problems, which occur, while specific therapy can be enzyme replacement, substrate reduction, or sometimes bone marrow transplantation. So the optimal care can be achieved whenever you have supportive and disease-specific treatment with a regular follow-up in a multidisciplinary setting who are experienced and managed for in LSDs. So if you see the points where the treatment strategies can be targeted, it can be at the genetic level where there is a correction of the gene itself, which is mutated, such as by gene therapy or a stop codon read through, or it can be where you prevent the degradation of or prevent the misfolded protein to happen or to unfold it in a proper way by chaperones, or you replace the enzyme itself by enzyme replacement therapies, where this is a major area for lysosomal storage disease. But there are also other things which play at a subcellular level which can be tackled, such as there is an autophagic pathway which can be tackled, or the substrate itself can be reduced. So because of the secondary cellular abnormalities which can happen, apart from the specific therapy targeted with the enzymes or substrate reduction, lot of other molecules can play a role in the management of lysosomal storage disease. So if you take the Gaucher disease, as you see, the goals or the target is first to initial assessment and then to have an goal such as the maintenance of the hemoglobin, the thrombocytopenia to be corrected, or and have an individualized dosing, then assess by regular monitoring and achieve and maintain these therapeutic goals by adjustment and regular follow-up. So for Gaucher, for example, you have the skeletal treatment or the management where there are no bone crisis, there may be no or very mild bone pain. The hemoglobin is above a certain level of 11 in females and above 12 in males. The platelet are maintained above 1,20,000, and the spleen and the liver size also decrease, so that the quality of life actually is good. So for that, definitely for Gaucher type 1, ERT is a very standard care, and also a substrate reduction therapy such as eliglustat. So our first patient to get ERT in CMC Velot was in 2006 for Gaucher, and he is now a major role for the Society of Lysosomal Storage Disorders, and he is managing well. He got married and now has a child as well. So this is one of the success stories. And similarly, for many of the lysosomal storage diseases, the enzymes are available from the time of 1991, where Genzyme Sanofi had started it, and through the charitable program, we also got it in 2006. So thanks to Sanofi, Genzyme, and subsequently so many other recombinant therapies have come up for Gaucher's, like you have velaglucerase by Shire or taliglucerase by Pfizer, and then of course for other lysosomal storage for hunters, there is BioMarine, which is making, and by Shire, and then for Morcues it's by BioMarine. For Fabry's again there is Genzyme, and as well as Shire, which is, or Takeda as it is known, is making, and there are many such enzymes which are with improvement for the others for better management, and because you know that there are some certain things which are the drawbacks of the enzymes. For example, they don't cross the blood-brain barrier, so you cannot expect the neurological component to be treated, such as for type 3 Gauchers, which is a major component in our Indian population. Similarly, for Pompe's, there are a lot of antibodies, or the CRIM positive and negative status has to be determined, and these all slowly decrease the effect of the enzymes or the ART, which is given from outside. So you have to be on a watch out and keep improving the management. So if you see for Gaucher's, like Gaucher's, most of the diseases are autosomal recessive, and you have parents as carriers, and the affected one will be homozygous for the disease mutation, while while this is for autosomal recessive, where you have a 25% chance of that each parent, so for any child to have such a disease if the parents are carriers. And similarly for most of the genetic lysosomal storage disease like Pompe's and Hurler's, it is an autosomal recessive, except for certain conditions such as Hunter's and Fabry's, where it's X-linked recessive. So talking a bit about the national policy for rare disease, which you can easily download from Google, there are certain aspects which have shown hope for these rare diseases. For example, renal transplant is possible under rare disease for Fabry disease, and if they are requiring that, it can be up to 20 lakhs can be paid by the rare disease policies. So these are like long-term treatments, diseases which require long-term treatment at a relatively lower cost, and can be monitored and can lead a normal life. But for other sorts of lysosomal storage disease, there is an evidence of good long-term outcome for Gaucher, Hurler, Pompe, Hunter, Fabry, and all these. But the enzyme replacement is costly, and therefore the national policy also says that considering the limited data available on rare disease and in light of competing health priorities, the focus would be on prevention of rare disease as a priority for all the three groups of rare disease identified by experts, public health, and hospitals, being a state subject, and the central government would encourage and support the state in their endeavors through screening and prevention of rare disease by centers of excellence under the rare disease policy and Nidan Kendra under DBT. So at one hand, it tries to give some amount, but it realizes that these are lifelong treatment where probably the funding would be exhausted, and therefore, unless the price of the medicine comes down, prevention is still the primary management part. So whenever you see a case of lysosomal storage disease, or for the matter any genetic disorder, genetic counseling becomes very important at the time of diagnosis. So we have to prepare the couple, we have to motivate. Just apart from giving the jargon of recurrence risk and what is the gene abnormality, we have to keep the hope of the couple, of the parents, the families alive, and motivate them, and also offer prenatal diagnosis. So procedures such as chorionic villus sampling and amniocentesis are levels of secondary prevention which have been mentioned in the national policy. Primary prevention at the moment may not be very feasible. So therefore, we look forward to secondary prevention by doing a CVS or a amniocentesis, getting the sample of the fetus, and then doing a molecular testing and giving a result of homozygous affected or heterozygous carrier or normal unaffected. In the secondary prevention, you have newborn screening and then early diagnosis and treatment, which Dr. Ashwin has already spoken about. And tertiary prevention is where you come to the actual management, which is specific, and you treat the complications which can vary from each disease to disease. So since every disease involves multiple systems, you have to be in a watch out for all the systems, and a multidisciplinary approach is very important. So there are some centers of excellence for rare disease, and these are all government set up. Unfortunately, CMC is not in this, and I hope that there will be in the future with your encouragement, and then we can also do that. Although we are already doing, there's a multiple disciplinary system which is working in CMC, and it caters to most of the aspects for rare disease. So anyway, we can see that in future, research and development is very important for searching new drugs and better drugs, which will be cost effective for a poor country like ours, where most of them are not affording these drugs. It is always a motivation for researchers to develop better drugs, which can be cost effective. So as in the future, you can see that new drugs are coming. The mTOR, which is a new treatment, and new trials can be continued for this till we find an optimum management policy for these rare diseases. So thank you, and thank you for this opportunity.
Thank you so much, ma'am, for your lecture. The best, we definitely, actually what you said, like, because India is a poor country, rather than just thinking that we would get all of the treatment through ERT or SRT, we should also focus on the management and the multidisciplinary aspect of it. Maybe that can actually benefit a lot of patients in waiting till these drugs are available. And at the same time, it is very important that we, in already families where this is detected, we have a prenatal diagnosis, and we do a counseling, a genetic counseling, and explain them all the different pros and cons and reproductive options they might have. With this, we move on to our next topic. Our next speaker is the keynote speaker, Dr. Ashok Velot. Welcome, sir, to the webinar. And Dr. Ashok Velot is a consultant pediatrician at the Metabolic Unit, Great Ormond Street Hospital for Children, NHS Foundation Trust, Honorary Reader, Clinical and Molecular Genetics Unit, UCL Institute of Child Health, which he was associated from 94 to 2016. He's a member of British Medical Association, Society for Study of Newborn Errors of Metabolism. He's a member of many international organizations. He has been chairman for the task force on the neuronopathic Gaucher disease, European Working Group on Gaucher disease, member Medical Advisory Board, European Genzyme Access Program. Today, Dr. Ashok Velot would be speaking on a very interesting topic, which is the emerging phenotypes in LSDs. Over to you, sir.
Thank you, Deepanjana. I hope the audio and video. So as has already been alluded to by Dr. Sumita, treatment is expensive, but there are a large number of patients now in India, thankfully, who are on treatment. So we have to be aware that there have been emerging phenotypes in lysosomal storage diseases. So I hope you can see my screen now.
Yes, sir. It is.
Thank you. Okay. So what do we mean when we talk about emerging phenotypes? Now, there are several long-term established treatments for LSDs, bone marrow transplant or hematopoietic stem cell transplant, as it's known as, enzyme replacement therapy, substrate reduction therapy. And as a result of these, many of the clinical features have been ameliorated, but no disease has been completely cured. We don't talk about complete correction or cure. Instead, what we see is a modification and the emergence of these new phenotypes. And these new phenotypes we can consider under two headings. Either they can be a modification of the natural history, or they can be an emergence of new clinical features as a result of what I refer to as sanctuary sites. Now let's talk about the modification of the natural history first. There are two areas that I'd like to consider. One is bone marrow transplantation for Hurler's disease or MPS 1H. And the second is enzyme replacement therapy for Pompe disease, early as well as late onset. So let's talk about Hurler's disease. The treatment of choice is a bone marrow transplant. The intellectual function is reasonably well preserved. The survival has been prolonged. The phenotype has been dramatically modified. You can see here 3 patients. Here at the top row, they are at the time of diagnosis and just before transplant. And here, many years later, you can see their facial features have been dramatically altered. And in fact, so here are 2 pictures that Ed Reid sent me many years ago. On the left, you see a child who's had a bone marrow transplant for Hurler's disease. And on the right is a child with the intermediate form of Hurler's or Hurler-Scheie. And you can see the similarities between them. Mild skeletal deformity, reasonably preserved intellectual function, and so on. Having said that, you see this progression of skeletal problems here. You can see the hip pathology progressing, progression of spinal deformity. They can develop cervical cord compression and lumbar cord compression. And the sort of late phenotypes are quite different. Here you have 3 patients, all transplanted reasonably early, but all quite different. So Paul on the left was the world's first transplant for Hurler's disease. He was in reasonably good condition, actually, except he was in a wheelchair, but sadly suddenly died a few years ago in his early 20s. Amy in the middle was referred because she had congestive heart failure at the age of 6 weeks. She had 2 bone marrow transplants, and although she is now in a wheelchair, she's actually quite well preserved and comes to the clinic on her own. Aaron, on the other hand, on the right, you can see, again, transplanted almost the same age, but very significantly disabled neurologically. So very different long-term phenotypes, and it's therefore very difficult to counsel these families at the time of presentation. Sometimes you just have to give them all the available scenarios and let them make up their own mind. Now, infantile Pompe disease is very well effectively treated by enzyme replacement therapy with a long-term excellent survival rate. But in the long term, we are seeing some emerging problems, varying degrees of muscle weakness, spasticity, scoliosis, hearing loss, speech and swallowing defects, and most worryingly, actually, cognitive decline. Here you have a child, take from Alex Broomfield's paper a few years ago, with, I hope this is obvious, progressive spasticity of the lower limbs. The same group reported these patients, long-term white matter changes in infantile, IOPD patients. You can see this periventricular white matter changes. This child is now 13 years old and has started developing these changes. And they are associated with cognitive decline in many patients. So this is something that we need to be aware of. Late onset Pompe disease, we see some long-term problems, smooth muscle involvement of either the lower airways or vascular system, hearing loss, mild cognitive impairment is nothing like what you see in the infantile patients, peripheral neuropathy, and GI problems. Now let's move on to sanctuary sites. What are sanctuary sites? Well, we can define them as areas in which it is difficult to get a sufficient concentration of the therapeutic agent, whatever that is. And initially, actually, these were described in cancer and HIV, and cells in these sites were shown to be resistant to therapy. And similar sites have now started emerging in LSDs. And as a prototype, I'm taking Gaucher disease. As we know, current treatment is very effective, but despite this, certain areas of resistance have emerged, and these are the lungs, the lymph nodes, also known as Gaucheromas, the eyes, and the teeth. I've just taken some examples, there are others. So let's talk about pulmonary disease. The common pulmonary manifestations are radiological, parenchymal infiltration, pulmonary hypertension, hepatopulmonary syndrome, or severe pulmonary hypertension. But this is an additional problem that we need to be aware of, that's interstitial lung disease. This can be quite silent. It's probably more frequent in type 3 and presents in the younger child with frequent episodes of wheezing and is often mistakenly treated as asthma. It can be resistant to bronchodilators and antibiotics. And the chest X-ray shows ground glass opacities. So here you can see a child with these ground glass opacities, classical interstitial lung pattern. And this is reflected in the CT scan. How do we manage them? It's difficult. Antibiotics are ineffective unless there's superadded infection. I've usually used a combination of oral and inhaled steroids. So we normally start prophylactic inhaled steroids. And for acute episodes, we give short courses of oral steroids. And importantly, it's quite important to give perioperative oral steroids as well. So you start a few days earlier and continue for a day or two later. Because otherwise you find that anesthesia can be extremely difficult. And in children who are treated with enzyme replacement, it gradually improves. It is thought that substrate reduction therapy confers additional benefit, even in patients who are on enzyme replacement. So here we have a patient of mine. You can see the upper line, this is when we started monitoring her when she was about 5 years old. We monitored her with the FVC and the FEV1. So the FEV1 is the red line and the FVC is the lower blue line. And they were both quite low. You can see that is as percentage of normal. She went on to the miglustat study and they both dramatically improved actually. And then, as some of you may know, we had to actually stop miglustat. So it was only a very short course, I think about 2 years. And after that, unfortunately, she wasn't monitored very carefully or frequently. She presented then with a pneumothorax. And at that time, we found that she had quite poor lung function. She had a second pneumothorax here with a VATS procedure, following which her lung function started deteriorating. And in fact, at that point, we put her on eliglustat. I think she was the first child to actually commence eliglustat. But the point I wanted to make was that this can be a very silent problem and may be responsive to enzyme replacement. This shows you her CT scans with extensive involvement. This is on the left, a lung biopsy from a patient who's been on treatment for many years with Gaucher disease. You can see the persistence of Gaucher cells. And the bronchoalveolar lavage also shows persistent Gaucher cells. You must remember to measure the diffusion capacity. What is diffusion capacity? You can read up the technology of this, but it is more sensitive than standard spirometry. Sorry, it measures the diffusion of the gases across the alveolar membrane. But it does need an adequate lung volume, approximately 1 liter. So that's not before the age of about 6. So lung involvement may be clinical, but it is often subclinical and regular monitoring is required. It may persist despite enzyme replacement therapy, and additional therapy may be needed, such as small molecules. Is there a role for bone marrow transplantation in lung disease? This is a single case report. Here you can see a patient whose lung disease progressed despite good doses of enzyme replacement. Here he had the bone marrow transplant, and here you can see quite a dramatic clearing of the lungs. I'm not advocating bone marrow transplant as a treatment. I'm just pointing out that it may get to areas that enzyme replacement therapy can't get to. By the way, the above patient also had Gaucheromas, which did not respond to bone marrow transplant. Lymph nodes or Gaucheromas, the most common areas are the mediastinum and the mesentery, but other areas can be involved, like the neck, but they're less common. So this was the first patient described with a mesenteric lymph node mass. This was in 2002. And this is her mass removed at surgery. It's usually an incidental finding, usually asymptomatic. And the biopsy shows storage cells, but they're atypical. They don't display the normal markers. There's no evidence of malignancy. Sometimes they're sometimes they're symptomatic with malabsorption, failure to thrive, or chylous ascites. They are refractory to enzyme replacement therapy. There have been recent reports of success with miglustat plus an oral budesonide, but I think it's fair to say that treatment is still very unsatisfactory. Eye involvement is something that's emerged in recent years. This is the first report actually back in 1980. Now, you get vitreous opacities in Gaucher disease, and they are often asymptomatic, or they can be floaters, the little specks that the patient describes. They can interfere with schoolwork. If they're very severe, a vitrectomy may be required, and sometimes you can get secondary glaucoma. So this patient has fairly mild involvement. You can see on the OCT that they're evident on the OCT as well, but they can progress. So this is a patient of mine who progressed to very severe involvement. She needed a vitrectomy. She developed secondary glaucoma, and sadly, she has now lost vision in both eyes. Dental involvement is something I wanted to raise. It's not obviously life-threatening or critical, but it is extremely unpleasant. And they all display very similar findings. You can see these abnormalities in the teeth and the CT scan, which shows these sort of cysts at the roots with absorption of the bone. It can be very unpleasant and disfiguring and very painful sometimes. It is important to remember that you can get multiple sanctuary sites becoming evident at different ages in the same patient. So this patient with Gaucher disease, she commenced the RT at the age of just over a year. A mesenteric mass, she's the one with the mesenteric mass node first described in the literature at the age of 3. She developed a sudden onset unilateral hearing loss at the age of 6, secondary to skull base infiltration. She developed a pneumothorax at the age of 10. So if it hadn't been for the fact that we were regularly monitoring her, she could have become quite disabled. and we could have missed many of these things. It is also important to emphasize that not all patients develop sanctuary sites. And it is unpredictable. So what is the importance of emerging phenotypes? It is important to the scientists because they can identify areas of resistance to treatment, and based on that, new therapeutic approaches can be designed. It is very important to clinicians because it raises new areas of concern that need to be monitored. It raises ethical questions about whether a particular therapy is appropriate. And it very much helps us to counsel new families. We are able to tell them now things that we were not able to tell them 20 years ago. So in conclusion, a careful clinical examination should be performed at every visit. Nothing should be taken for granted. A systematic, regular follow-up at designated centers of excellence is essential. None of these patients would have been picked up had they not been monitored at centers of excellence. Technology has no place at the bedside. There is no substitute for careful clinical practice. Thank you very much.
Thank you so much, sir, for such a wonderful presentation and to see the spectrum of all these phenotypes. More interestingly, it's really important, again, what Dr. Sumita Danda had emphasized, that no matter whether the patient is receiving ERT or is on a stem cell transplant, it's very important to look at the different aspects, and the multidisciplinary team should be involved when we are managing such patients. More importantly, because I am a genetic counselor, I feel I would like to ask you this question maybe at the end of the session, that whether different genotypes have any effect on these phenotypes, and whether the spectrum of disorders have anything to do with the location of these mutations and what type of mutations they are. Because in certain cases, we do see that the attenuated forms or the severe forms might be related to the genotypes, though it's not fully verified at the moment. With this, we come to our next speaker, and I am very glad to introduce Lieutenant Colonel Dr. Aradhana Dwivedi. Welcome, ma'am, to the webinar. She is an Assistant Professor, Army Hospital Research and Referral Center, Delhi, and she's the alumni of the prestigious Armed Force Medical College, Pune. Being the first geneticist from the Armed Forces Medical Service, she's vested with the responsibility of setting up the first nodal center for genetic disorders, where there will be diagnostics, training, and research in Indian Armed Forces. Her area of interest include lysosomal storage disorder, dysmorphology, inborn errors of metabolism, neuromuscular disorders, and neurodegenerative disorders. Today, Lieutenant Colonel Dr. Aradhana Dwivedi would be speaking on multidisciplinary care. Over to you, ma'am.
Thank you so much, Dr. Dipanjana, and good evening, everyone. First of all, I would thank Mr. Saurav for making me part of this webinar with such esteemed speakers. A lot have been covered about lysosomal storage disorders. I would be just expressing an overview of multidisciplinary care in LSDs and basically the challenges which we are facing in India, and are there any ways to overcome those. Yeah, I'll just share this slide. Okay, so when we talk about the multidisciplinary care, why it is important? Because as we have understood that LSDs, if you look at LSDs, so it doesn't, the manifestations of LSDs is not limited to one organ or organ system. It's a widespread involvement, in fact, affecting almost every system, some more than the other, and that depends on the underlying LSD. So as you see in this slide, none of the system is spared by different types of LSDs, which is designated by their genes here. So, and secondly, we see the widespread manifestations Secondly, the long-term morbidity. It's a lifelong morbidity or life-limiting disease. So that requires chronic support from family, chronic support from the society. And thirdly, if you look at the treatment part, so treatment, either it is no definitive treatment is available for most, and if at all it is available, the cost is prohibitive. So to assist them, we need some financial support also. So it becomes a team of not only clinicians, it's a team from the psychological supports, social workers, as well as some financial things. So when all these come together, it becomes a multimodal approach. And with the treatment goals of this multimodal approach is to stabilize, improve, and if possible, reverse the clinical signs and symptoms. So if we outline the management of LSDs, it would be just as we have understood, based on the clinical features, we go for the enzymatic diagnosis. After that, molecular testing, do the genetic counseling, quantify the phenotype, plan the treatment goals, and then for every patient, have a personalized approach. Because for the same thing, with the similar disease, we know that every patient would be different. So ideally, we should have a personalized approach for each and every patient. What happens in the multidisciplinary management? There's a core team along with the group lead consultant. Along with that, there's a support team. So if we look at this core expertise for the multidisciplinary care, so what are the services would be your clinical services and so we have clinical services, diagnostic services, and support. So as I said, in the clinical services, there is a primary doctor who would label as a lead consultant, who is primarily responsible for looking after the patient. So that could be pediatrician or internal medicine specialist, or it could be geneticist. Along with that, he ties up with other, depending on the manifestations, what the patients have, along with cardiologists, neurologists. Then you have a team, audio, ophthalm, physiotherapy, psychology, and all under one roof preferably. So ideal setup is that for the, like suppose we have a Gaussian clinic or we have MPS clinics. So all these sit together under one roof and then consult, all concerns are addressed, as the previous speakers, Dr. Sumita ma'am also mentioned, like some would need orthopedic intervention, some Gaussian may need splenectomy with surgical involvement is there. So when all these come together and they decide what is best suited for that patient. Besides that, the presence of diagnostic services, including pathology, genetics, radiology, and your support services like pharmacy, administrative support, a lot of financial advice, social services, and the patient support group, which come together to give a very comprehensive approach and multidisciplinary management of these disorders. So what is the role? This group, they together, first of all, they define the problem, they decide on their goals, they gather information, seek and offer opinion. It's important to respect each other's opinion in this multidisciplinary care and develop some potential solutions. So basically it has to be patient-centered, not doctor-centered approach, so that everyone understands what is the best for that patient. Then evaluate the potential solutions and choose the best one, summarizing the plan and agrees on the distribution of tasks across team members. And what the key to success of these MDTs is basically involvement of all team members, having good communication, no gaps, working towards the treatment standards, and give patient information through an individualized written report. So if we look, this is what we are talking about, the ideal setup. Maybe in Western it is existing. As far as we go in Indian setup, first, as we have seen, there is a gap in the management. Reason being, if you look at the typical health structure, so mostly 80% of the outpatient and about 60% of the inpatient care is provided by the private sector in India. Majority limited by nursing homes and small scale hospitals. So if you look at this, how much is feasible to get multidisciplinary treatment under one roof in these hospitals? Maybe, and if at all, you see most of the healthcare in India is individual based rather than institutional based. And it's really difficult to get all the clinicians. First of all, in smaller cities, they would not be available. All the clinicians or all the sub-specialists may not be available. And if they are available, it would be difficult to get them, especially in a public sector. Public sector is where ideal MDTs feasible are very few in number. And if because of the load, problem load is for any health problem, we have got immense load, patient load. So getting them for one case or for that particular clinic, as of now, it may be sounding it's a vague idea, but if we start doing, and since like there is so much awareness has spread in last few years about LSDs and for other rare disorders for that matter, so gradually this MDT would become the main. We will start understanding the role of MDT, and we would start incorporating it in our day-to-day life and management of these patients. So, and if you look at the corporate sectors, yes, corporate it's feasible. We can get all these subspecialties under one roof, all this care, but how many patients can afford that? That is a question. So as maybe the picture may not look so gloomy, we can still think that for the smaller cities wherein for second tier and third tier cities in India, somebody can take the responsibility, maybe the lead consultant or the primary care physician who is the prime person, then he can see what are maybe not under one roof, but one can tie up like what are the specialties which are available in the city, what is the infrastructure existing, then are they willing to take opinions and offer opinions. So based on that, have to have a timely communication. Maybe one has seen the patient here today, we feel that yes, this patient needs Morco patient needs orthopedic management. So just consultation with the orthopedic and arranging for a transportation. And then this also can be planned and at least can be done till we have everything under one roof in house with that. But all these should be patient centered. And nowadays through social media, and there are various with the help of technologies, one can always come together. And if not meeting physically, obviously virtually, patient can be addressed, and all of us, but this is one of the proposals that they all can sit together and have a meeting, and then obviously depending on the need of the patient, he can visit various specialists. So this is the present take on multidisciplinary management of these LSDs. And if we look at something like that, we have tried to develop at our hospital. So we call it Vatsalya and the pediatric OPD complex. And we have day-wise, we integrated our theme clinics, we say, like suppose Monday we have a fetal-maternal genetic and pediatric cardio. So we have high-risk antenatal, neurogenetic, hematogenetic, and cardiology clinic. So all these patients who come, suppose a patient of some neurological disorders, underlying genetics come, he's being seen by geneticist, neurologist. And then if there is a fetal-maternal and side, so we are doing all procedures also. Suppose there's a prenatal diagnosis has to be provided, and additionally echocardiography and other things are done. So just to minimize the patient exposure and minimize the patient visit, that came really handy in especially during COVID times of this. So, and then definitely patient, if you provide all these things in a day or so in your integrated clinics, then you'll realize that patients also become the frustration of going here and there and doing all those works, investigations and workups. Obviously, it becomes easier for the patient. So we can develop gradually all these theme clinics or integrated clinics, if not at a complete thing, but gradually at least 2-3 subspecialties, they can come together and they can address the problem of these kind of patients wherein the system, multi-system involvement is there. So I think this is just an overview and about this multidisciplinary care. And if there are any questions, I would be happy to take at the end of this. Thank you so much.
Thank you, Lieutenant Colonel Dr. Aradhana. And it's such a wonderful thing to integrate all the other management components into the care and develop a standard of care. I believe that in many of the premium centers, we do have these kind of standard of care and multidisciplinary care there, but it becomes very difficult for patients to actually go and approach them because these are not present as often enough in the areas where it should be, because they are localized in certain regions. The other aspect which actually is wonderful to see, the psychological part of the counseling. Psychological counseling, especially to index children who are getting ERT or who are getting management or surgeries, are very important because to improve their quality of life, because there might be certain psychological impact to understand what they are going through and that they are a bit different from the peers, and to normalize them. At the same time, family counseling is also very essential because the family has been through a lot, and for them also, a very consolidated family counseling is very, very important to understand, to take care of their mental health. With this, we have come to an end of the erudite speakers which we had for the webinar. Are there any questions? I cannot see anything on the chat box, but if there are any questions, then we can take them up. If not, then I have a few questions for all of you. Sir, Dr. Ashok Velot, sir, if you can please take this question up on the genotype and phenotype, and then if ma'am, Dr. Danda, Dr. Dalal, and Dr. Radhana can add on to that.
Yes, sure, I'll try. So I think your question was about genotype-phenotype correlation in India.
Right.
And certainly in it's not very clear cut for many of the LSDs. There is some correlation in conditions like MPS, severe MPS 1, infantile Pompe. In general, the more severe, as we know, the more severe the mutation, like a complete deletion or an inversion, will result in more severe disease. And this is seen, for example, in MPS 2, where you have the common inversion. I think also we should consider in India that there is a huge effect of endogamy, and we see certain communities where there is a higher prevalence, I'm talking about generally, of certain genetic diseases. And this has been well described. And this is actually not related to consanguinity, but to endogamy. Actually, endogamy seems to be the bigger problem in India than consanguinity. A typical example would be the spinocerebellar ataxia that we see in the Agarwal community, and so on. So if we identify certain mutations in particular communities, then we can home in on those mutations. That will make it far more efficient. We can also apply deep learning and artificial intelligence techniques once we have an awareness of the community involvement and the particular phenotypes that we are looking for. Of course, this is very dependent on accurate description of phenotypes and correct definition or correct delineation of the genotypes. I notice, I mean, I'll be corrected if others can come in, but there doesn't seem to be a national variant database. There are several that I've seen, but there doesn't seem to be a national one to which a geneticist can just go click on that and say, okay, this is what I'm looking, and that would be extremely helpful.
I agree. I totally agree, sir. And that's why I have been advocating a possible epidemiological study across India, if that's possible, for each of these disorders, at least the ones which are manageable or treatable. Let's, Madam, Dr. Sumita Danda, Madam, if you would like to add anything onto it.
No, I perfectly agree with Dr. Velodi. There has been attempts from the Society of Medical Genetics, and I'm sure Ashwin can add on more, where we can actually put into the database whatever variants we are finding. It would be eventually very helpful. But the time is the factor. For clinicians, the time is the factor. When we are seeing so many patients and we are more dealing with the management than really sitting and creating databases, putting into that the entry for the databases. Initially, we were I tried putting in some, but after that the follow up doesn't really happen. So I think we are lacking in that really. But I hope that some way the database will be created. And there are another thing is that there are a lot of commercial labs which are doing the genetics tests, so they actually are probably have the facility or the work, the manpower to do and enter that. And it is just a time, I mean, time will tell us whether we can really coordinate or collaborate with them and then form a final sort of a consortium or something where the patients really will benefit. So, and our genetic counselors as well as medical geneticists will benefit, and it would be an excellent database if we can really do it. So I would give over to Ashwin to speak on it.
Sir, Dr. Dalal? Sir, are you there? I believe sir has certain problem or he's not available at the moment. Dr. Aradhana, do you want to add anything to that?
I totally agree with obviously Velot sir and Sumita ma'am, and I think there was some attempt by Society of Indian Academy of Medical Genetics, because with Ashwin sir, Shubha ma'am, and obviously Sumita ma'am, others. So we were making some database, and they were collecting data from all these centers for Indian, not only for LSDs, but all
For all disorders.
Yes, that was for all. This was happening. Obviously, sir can give better insight into this, but unfortunately, I think we have lost him.
Yes.
Over this.
Yes, ma'am, another, to Sir, ma'am, everybody in this panel, my another question is, in India, we have been using, like especially Sumita Danda ma'am and Ashwin sir, you have been using this ERT for very long in India, unlike, you know, in other centers, and Dr. Velot sir also. What do you see about, you know, there were certain talks about antibodies against these ERTs, which make them less effective after a certain amount of time. Any comments or questions on that? Though I don't think we are there, but still as a comment or a question, like any comment on this particular topic, because there were some papers which said that in Pompey's disease there was some autoantibodies that were generated which were sort of inhibiting the good part of the ERT, and it wasn't working after a certain amount of time. So if you would take it, Dr.
So maybe
Velot,
I can, yeah. So of course, this was really first described and pioneered in Pompe disease by the groups from Duke University led by Priya Krishnani and people from the Netherlands and so on. And this is well known, and it's been shown that patients who are CRIM negative have a higher risk of developing neutralizing antibodies, and that the development of these antibodies can be prevented by immunoprophylaxis. So I think Pompe was really the prototype for this, but it has been extended to other diseases, specifically MPS 1. People have tried. Gaucher disease is not such an issue because most patients have some residual enzyme activity and they're not CRIM negative. So their risk of forming neutralizing antibodies is quite low. But yes, I think this is a very important area that needs to be developed. I would like to just ask one question, which is, Dr. Sumita was talking about the national policy that has just been launched. And I noticed that, I mean, on the one hand, the government say that prevention is important, but having read the report, I can't see any mention of funding for pre-implantation genetic diagnosis. I mean, that is an area that is absolutely crucial for India. I think if we are, and if they're designating so much money per center, why not some of that for PGD? Nothing has been mentioned.
Yeah, exactly. There is no mention. I think technologically it is not available in many centers, and not. I don't think that any government setup is carrying out PGD at the moment. It is all private related. CMC also doesn't have PGD yet because of license problems and ethical issues and such issues. So I think that has not come into the picture yet. But probably I think it's a very good idea, sir, that we can propose and we can put up and to have a center for excellence. One of them at least can have a PGD. So,
Sir, actually, the main problem over here, sir, is when the counseling takes place, sir. Most of here, we are across a huge amount of socio-religious background. So, in most of these cases, IVF, going into IVF, number one, has a financial issue. Most of the private places which are practicing it, the prices are in the zone of 3 lakhs to 4 lakhs, which is not affordable by common man. Also, sir, there is some inhibition. Even if we ask for a donation, a gamete donation, there is some inhibition because of the religious part of it. Hence, the counseling part of it becomes very important. So, in the rare disease policy, they do mention about the prenatal diagnosis, but the pre-implantation is not mentioned because
That's right.
it is not developed very well across India, sir. And the affordability of the IVF centers is again a huge issue, sir. So that's probably one of the reasons, sir.
I don't dispute that, but the point is that the government has said that money will be put in, and especially for equipment and staffing and so on. But anyway, this discussion can go on.
yeah, I mean, exactly. It is, I mean, it may cost up to 5 lakhs, 6 lakhs, but it is much less than what you are expecting to treat a lifelong disease. So that idea has to go into the health policy probably. So we thank you for reminding it. But yeah.
So we are running a bit short on time. So with everybody's, it's a wonderful discussion, and it's really nice to discuss all these points on a national forum as well.
We've cut off.
Hello, am I audible?
I can't hear anyone.
Hello, am I audible?
Yeah, yeah, I can hear you. I think there is a time limit, so it'll.
Yes, yes. So
okay, thank you. Bye.
So there is basically a video, short video by the associate partner Sanofi. So I would request the IT team to please play the video.
Lysosomal storage disorders, or LSDs, are a group of inherited metabolic diseases. Each is caused by one or more mutations that result in the deficiency or malfunction of lysosomal enzymes. Lysosomes are organelles within cells that contain multiple degradative enzymes, which serve to break down different types of biomolecules. In most LSDs, due to the reduced activity of functional enzyme, the lysosome's ability to break down complex macromolecules is impaired. These large, undigested molecules then accumulate within the cells, eventually leading to cellular and tissue damage. LSDs are progressive and over time may lead to increased disability and premature death. For these conditions, timely diagnosis is important in respect to optimal disease management. To assist with accurate diagnosis, dried blood spot (DBS) testing is available. DBS tests are easy to use, inexpensive, and reliable for testing if the following simple guidelines are followed. Firstly, all data fields on the DBS card must be completed for each patient. Dried blood spot specimens are obtained by collecting and applying whole blood to specially designed specimen collection paper. In patients over a year old, whole blood is most commonly collected through a finger prick. The blood should be applied to each circle on the DBS card. The blood should cover the whole circle. Laboratories may also accept samples collected by standard venipuncture. Blood can often be collected in EDTA tubes, but the performing laboratory should be firstly consulted. Collect venous blood in a collection tube and immediately invert the tube to mix the additive. Blood can be transferred using a pipette under the appropriate safety equipment. Hold the pipette tip above the center of a circle close to the surface but without touching it. Gradually discharge the blood and let it soak into the paper, filling the circle completely with a single application. Repeat the procedure for all remaining circles of the filter paper. Incorrect sample handling may lead to false positive results or sample rejection. Therefore, make sure the blood is properly collected. To preserve enzyme activity, samples must be dried at room temperature for at least 3 hours, away from direct heat or sunlight. To avoid cross-contamination, do not stack cards. Cover samples after they are dry. Dbs specimens are classified by the International Air Transporter Association, IATA, the World Health Organization's Guidance on Regulations for the Transport of Infectious Substances, and by the International Civil Aviation Organization as a non-regulated exempt material. This makes DBS easy and safe to be shipped by regular mail when your local regulations and institutional policies for packaging and labeling are followed. DBS-based tests enable quantification of enzyme activity and easy sample collection. Positive DBS results should be confirmed as per local guidelines, often by either enzymatic activity on white blood cells from venous sample or tissue and/or genetic analysis of the suspected lysosomal storage disorder. Lysosomal storage disorders, or LSDs, are a group of inherited metabolic diseases.
Thank you so much, everyone, for your patience all through the session. I thank the speakers, I thank the co-sponsors, and I thank Mr. Saurav Singh for having all of us here. And with this, I end the session, and I would request Mr. Saurav Singh to please deliver the vote of thanks and close the webinar.
Yeah. Thank you so much to all for your wonderful input on LSD treatment and management. With all your support now, we feel we are rare but not alone. One day the time will definitely come when all the LSD patients will get their treatment very smoothly. Thank you so much, Dr. Ashok Velot sir, Dr. Ashwin Dalal sir, Dr. Sumita Danda ma'am, Lieutenant Colonel Dr. Aradhana and Dr. Deepanjana for participating in this wonderful webinar. Thank you so much.